2D echocardiography, we may encounter amazingly thickened IVS, much more thickened than the posterior wall, and this difference will be noticed as long as in short X and all apical and subcostal views where the IVS is depicted. This is the main finding. However, we will encounter that always the inferior or posterior wall will be less thickened, but not necessarily than the IVS. The main hypertrophied wall may as well be the anterior or the anterolateral walls, or the whole walls from the inferior IVS to the posterior lateral wall, as seen in this case. So here is a typical hypertrophic cardiomyopathy. There is an IVS as much thicker than the posterior wall. Notice the characteristics granulations that resembles rice grain within the IVS. There is also an abnormal position of the anterolateral papillary muscle, which seems to be dislodged anteriorly to a 1 or 2 o'clock position instead of its normal settings at 4 or 5 o'clock. The mitral valve is also angling its tips toward the left ventricular outflow tract. Let's see these features with more details. Here we have an asymmetric hypertrophy of the left ventricle with obvious more thickness of the IVS than the posterior wall. Notice that during systole the IVS width is like the posterior wall. The IVS shows the rice grains granulations. The IVS hypertrophy is uniform with about the same thickness from the subaortic region to more apically. There is a systolic anterior motion of the mitral valve, the SAM, in direction to the IVS. The region of the mitral valve that seems to be cords and not the anterior leaflet are projected to the left ventricular outflow tract. Look at this more echogenic area at the endocardium of the IVS, right where the cords touch the IVS. In this case, the hypertrophy is not as evident as the immediate subaortic region, but at mid-septum. The local where the IVS is more hypertrophied varies a lot. In this case, it is mostly subaortic and then becomes uniform. Watch now, the IVS is coming inside the left ventricular outflow tract, reducing the size of the subaortic region. In a short X, we see many kinds of hypertrophy. Here we have an example where the hypertrophy is limited to the IVS. In this case, also the hypertrophy is almost limited to the IVS with just a small region of the inferior wall. In this case, besides the whole IVS, there is also hypertrophy of the anterior wall. And now, the IVS anterolateral wall and part of the inferior wall. In this case, the predominance is of the anterolateral wall. As you can see, each case is a different type of hypertrophy. Not always the IVS is the thickest region. All these type here where the thickest region is subaortic, except this one may present subaortic stenosis. As you can see, each case is a different type of hypertrophy. Not always the IVS is the thickest region. The IVS granulation may be mild or intense. Occasionally, we see a line of greater refringence right at the middle of the IVS. This is not a rare appearance. The IVS seems to be divided into two sides. Another abnormality as said before, is the situation of the anterolateral papillary muscle more anteriorly at 1 or 2 o'clock. Another different aspect of the left ventricle is this banana shape. All these are characteristic of the hypertrophic cardiomyopathy.